Hi, everyone. Thank you so much for listening in today. Today we have with us a very special guest, Dr. Edward Nejat from Generation Next in New York City. He is a reproductive endocrinologist who considers the doctor-patient relationship to be paramount. He also happens to specialize in women in IVF over the age of 40 and has some clinical pearls to share with us today. Thank you so much for being with us today, Dr. Nejat.
Christina, thank you so much for having me.
Okay, great. So let's dive right in. Tell us a little bit about your background.
Sure. So I was born and raised on Long Island, Nassau County, born to Iranian immigrants who came to the United States in the 60s. And for college, I was in Nassau until college, at which point I came to Manhattan in 96, went to NYU for undergrad, majored in biology, and then stayed in the city for medical school. I went to Cornell. And as I was going through medical school, learned pretty early on that practicing medicine was certainly always going to be my passion, but I wanted to do it on a scale that was going to have a bigger impact. And in order to open up opportunities, I pursued a dual degree at Cornell between the medical college and the business school, and got my MBA right after graduating medical school, which was an incredible experience. Came back to, and that part was in Ithaca, came back to Manhattan for residency training at Cornell, followed by fellowship training in reproductive endocrinology and infertility at Albert Einstein in the Bronx in Westchester. And then worked in private practice in Manhattan after that at a place called New Hope Fertility. And I learned a lot there. It was a great post-training experience for me. And at that point in my career, even earlier than that, I had been planning to start a private practice. And after working, and that's where I met Janelle Luke. We were at New Hope together for a year. We then moved on to a different private practice where we worked for 3 years, and there we met Jesse Haid, who is a colleague who works with us now at Generation Next. And after a few years in that private practice, Dr. Luke and I decided to co-found Generation Next, which we did in 2017. And it's been 5.5 years here, and it's been amazing.
So just for our listeners, I see a lot of patients that go to Generation Next and they have been loving their treatment. The results are great. The experience at the center is great. All right. So you consider the doctor-patient relationship to be very important, and that's come through in conversations I've had with some of your patients, that they really feel supported, they're in communication with you, they feel like you're empathetic. Why do you feel like that's important, and why do you take that approach?
The challenge that our patients are going through is central to most of their lives while they're with us. And to be able to partner with them rather than kind of take charge of the entire process, to be able to listen and work with them in tandem rather than dictating every single step of the process. Now, of course, I'm going to give my opinion every step of the way, but there are lots of different ways to pursue fertility treatments, and there isn't always one correct way. It's quite common that there's more than one reasonable option, and it takes time and patience to open up the conversation, present the options, then make a recommendation, rather than saying, okay, this is what we're going to do. And for some patients, the this is what we're going to do approach might be the right approach. It's not my style, and I think patients gravitate towards me because they really want more of a dialogue, and they want to be in control of their reproductive journey. And I think that my impression is, after doing this for as long as I have, a lot of the pain that patients are suffering from is this lack of control, because most people don't think that fertility is going to be an issue for them, and when it is quite tragic and devastating, understandably, and it becomes really difficult to regain control of that part of life. But I think that's really central in how we empower patients and how we enable patients to be in the driver's seat of their journey.
That's amazing. And it sounds like a very nice balance because, I've heard some cases where there have been doctors that have been like, well, what do you want to do? And the patient's like, no, I want you to tell me what you think we should do. So you need that guidance. It's your specialty, but to involve them in the process and to be definitely listening to them and taking into account their their own research, their wants, their desires, their goals. So that's really important. And I hear you on feeling out of control. I think that is a big part of this journey, and I think the communication is key in helping soften that part of the experience. What
Yeah, and I'll elaborate one step further, if I may. I've also been a patient with physicians in many capacities, and I also don't feel like it's fair when the doctor says, "Okay, what do you want to do?" Patients come to us because we're experts. That's what they're here for, and of course, they want our opinion and they deserve our opinion. So, I'm always going to give you the opinion, but sometimes I'll give the opinion and the patient will be like, I appreciate that, but actually I'm not ready for IVF. I want to do another IUI. It's usually a reasonable alternative. And I have no problem going with that, following the patient's lead in circumstances like that.
That's great. Yeah, because sometimes the heart and the mind have to catch up to, maybe what's needed or what's going to be the right protocol. And I do find that sometimes there is a logical order of steps to help the patient arrive at maybe the most effective protocol for them. I interviewed somebody recently, a patient, about her fertility journey. And she was like, okay, you give your doctor 1 or 2 cycles, and if it hasn't worked, then you move on. And I was sort of like, oh, I don't totally agree, because I think there is a bit of trial and error, sadly. It's not always going to be home run on the first one or the second one. What are your thoughts around finessing or troubleshooting with cycles? Because some doctors will say, no, we keep doing the same one and eventually it'll be effective. What's your approach with something like that?
Yeah, it's a great question, and I think there's a simple answer, which is, if it didn't work the first time, why would you try it again? And I think there is wisdom in that, and that is generally my approach. If we don't get the desired outcome, whether it's egg quantity or egg quality or embryo quality or what have you, yeah, certainly we'll make adjustments to the protocol to try and optimize the outcome with the next attempt. And I think that's really important, because doing the same thing over and over again, it doesn't make patients feel confident. It doesn't make me feel confident as a physician. But I will say there is another element to all of this, which is really less tangible and more difficult to pinpoint, which is it just a given menstrual cycle that's going to yield a better result because there are more follicles, or the follicles are similarly sized as opposed to the previous cycle when they weren't? Or are the follicles in a given menstrual cycle, for whatever reason, more destined to yield euploid embryos, chromosomally normal embryos? I think that element exists to a certain degree, and it shouldn't be ignored. I think it has to be acknowledged, because we don't have all the answers. It's not like if we do one cycle with a poor outcome and the next cycle is a great outcome with a different protocol, was it necessarily the protocol? Hopefully, I mean, probably to a certain extent, but could it also have been just related to chance and circumstance to a certain degree of what the inherent biology of that cycle was? I think that shouldn't be completely discounted.
Mhm. No, that's very interesting because, we see that, the patient will go in at the beginning of the cycle. You'll, take a look at the lay of the land and, you know, are there a lot of follicles? Is there one or two? Is it worth starting with this cycle? And I'm wondering from your perspective. So in the natural side of things, like we have our own sort of theories about what can influence the beginning of a cycle. I'm wondering in your field, has there been anything that's been identified, like lifestyle factors or otherwise, that can result in one cycle having, almost no follicles and another cycle, being a great start?
It's a good question with no easy answer. I think that as far as like what factors we're looking at, we're always looking at follicle quantity and size during menstruation before cycle start. We're looking at hormone levels, specifically FSH, estradiol, most notably, LH as well, progesterone. But we're also, listening to the patient in terms of what's going on in her life. Is it an exceptionally stressful time in life where maybe it's not the right time to dive into IVF? Was there a recent illness, COVID or otherwise, that might be playing a role in this upcoming cycle that might yield a suboptimal outcome? Or, we always want to go into an IVF cycle with full confidence that like, okay, we're ready, patient's ready, everything feels like this is the right time to start, rather than we aren't sure, we go into it, and then we don't see the desired outcome, and then we're kicking ourselves saying, oh, we shouldn't have done this, we should have just waited a cycle. And that's always a balance, because there's always a sense of urgency. Well, not always, but there's often a sense of urgency for patients to, go into cycles and not be waiting and continuing to try naturally. But that's very patient specific and circumstance specific. It really has many factors that weigh in, but it's an important part of the conversation with every cycle start.
Definitely, but you bring up a good point that, going in when it's kind of, quite suboptimal is tough, because I think it's really traumatizing for the patient too when a cycle doesn't go well. Like obviously you as the doctor are, not happy with the results, and feel that, feel that you really want to be of service in the best way that you can. And the patient is traumatized by the disappointment and, this, what they perceive as like failure of their body to perform. That said, there are some patients that like every time they go in, there's a cyst, there's low follicles, there's high FSH, there's, and at some point you have to get started,
Totally.
which is, I imagine, just a really tough call for you. So on that,
Yeah.
what are some of the special considerations for women in their 40s that are pursuing fertility treatment?
So, it's women in their 40s. It's I would say maybe most of our patients are in their 40s, or nearly most of them. It is an area where we specialize, and I specialize here at Generation Next. Many of our patients have cycled elsewhere and have not been successful. Many of our patients have diminished ovarian reserve or low egg count, low egg quantity. And these are areas where we really do excel. So with every patient, and including, regardless of age, we're very in tune to the history. How long have they been trying? Any medical problems? Any gynecologic issues? Have they been evaluated before? Have they undergone treatments before? If so, protocol types, and the outcomes. How many eggs, quality of the embryos. These are all really critical factors in developing a treatment plan, because a lot can be learned from what has or hasn't worked in the past. More specifically, with women in their 40s, sure, egg reserve, egg quantity is likely to be lower, because that's a normal biological phenomenon as women do get older. And oftentimes in women with lower egg reserve, conventional or more aggressive IVF protocols aren't as successful as we hope they will be, whether it's in regards to egg quantity or the way the embryos develop. And those are the patients who usually will benefit most from the mild stimulation protocols that we use, where instead of, pushing the pedal to the metal as hard as we can, we're working with the body's natural hormones. We know that FSH is going to be a little bit higher at baseline, and FSH is follicle stimulating hormone. This is the hormone that promotes the growth of the follicles in the ovaries. So if a patient's own FSH is already high, we don't need to be giving super high doses on top of that. We work with that. We use that to our advantage. We use lower doses of the injections, often in combination with pills like Clomid or Letrozole, to stimulate the ovaries more gently, with the goal of retrieving higher quality eggs that are more likely to yield higher quality embryos.
That's great. And I love that. I also, love that with your center, you have consideration for these different types of protocols for, the various fertility profiles that you see. Also, cost wise, it can be very favorable to be using, less of the injectable medication. So that's kind of nice for those, paying out of pocket for these things. Why do you think it is that in your field, like some of the more academic institutions or, some of your colleagues are more resistant to the low stimulation protocols? Like they just haven't been more widely adopted.
It's a great question. I think there are a few reasons. I think one is mild stimulation protocols arose in the East, in Japan more specifically, and Western or American adoption of those approaches tends to lag. Whether we're talking about acupuncture and Eastern medicine, or protocols that arise from the East. And just a sidebar, another similar example of that is luteal phase stimulation, or duo-stim, which is where we do an IVF cycle, we get to egg retrieval, we retrieve eggs, we see that there are several small follicles remaining in the ovaries between, say, 8 and 12 millimeters. They're not ready to be retrieved at the time of the first egg retrieval. So we'll continue to stimulate the ovaries for another week or so, do a second egg retrieval at that time, and really get a second chance in a single cycle to retrieve more eggs and create more embryos. But back to the
no, that's great. I've seen that really successful for women over the age of 40 and with low ovarian.
Yes, exactly.
And it's so great. This is, like more progressive centers like you guys are doing these types of cycles, and it feels like a very productive month in a lot of ways for patients too, because they've done 2 retrievals and hopefully then had a little bit more luck banking or whatever approach they're taking. So that's great that you mentioned that. Thank you.
And then just to answer the question about protocols and natural cycle protocols, when we go through training at academic centers, it's pretty standardized across the country and been at the forefront. And there's an inherent inertia in the training programs that is, so it slows the adoption of newer protocols and newer techniques pretty significantly. So I think that's part of the issue, because I learned these techniques not in my training. I learned these techniques after completing my training at the private practices that I worked at, and I was like, wow, this really works. This is amazing, but it has to be for the right patient. So patient selection is really important. You can't just do mild IVF for everybody. It's not the right choice for everybody. A 32-year-old with normal ovarian reserve would fare better with a conventional protocol because we will get more eggs and more embryos. So it is very patient specific in terms of who we're selecting, and making those determinations is labor intensive. It requires much deeper thought. It's much easier to be a large center and be like, okay, everyone is getting the same conventional protocol, IVF, PICSI, PGT, that's it. It's operationally a lot easier for a center to do that. It's much more difficult to treat everyone as an individual, and really look into their history, have a conversation with them about the options, and talk about, what's going to be the best option for them.
That's such a good point.
But
I've
we owe that to our patients. We absolutely owe that to our patients, and it's the only way I could imagine practicing.
I love that, and I'm so happy to hear that that's the approach you take, because I tell my patients sometimes they're frustrated, they don't feel like their doctor's listening to them, and I'm like, if you're in a situation where they're not changing the protocol, you don't feel like you're being heard, you can't get a hold of them, it's probably not that the doctor, is a bad person and not a good doctor. It's probably that they're in survival mode. It is the way that their particular center institution is set up, that there's a bureaucracy. They probably are all following a lot of the similar protocols. There's not a lot of time to think. And I said, you need to find someone that is going to listen to you, and that is going to think critically about your case and really map it out. Like, you definitely don't want the factory where they're going to be doing the same thing all the time. There
Right.
are all those people who fit within that box, the 32-year-old with, the good ovarian reserve, maybe. But even then, like, sometimes there are odd nuances that were unexpected.
Absolutely.
What are some of the other things that you do differently at Generation Next?
I think what we built the practice on is putting the patient's experience at the center of everything. So it's not just about the science, it's not just about the medicine.
I think the key is that you care. You care a lot about the patient's experience, and this is a stressful journey to be on, and you do your best to make it as pleasant to be a fertility patient as you possibly can, right? And yeah, it's running a business, and being a primary practitioner where you're seeing all the patients is tricky. But the good thing about you seeing the patients is that you're going to hear about how their experience is, and
Oh yeah.
so you're going to be able to really hone in on those areas that need attention. So are there anything, lifestyle wise or treatment wise that you do or you counsel in to help patients optimize their potential cycles?
Well, I think that brings me to Eastern medicine and acupuncture as a complement to IVF and fertility in general. In our training and in our medical field, we understand a lot. We know a lot. We have a lot of experience, but we don't understand everything. And there's tremendous knowledge for centuries of a different approach with Eastern medicine and acupuncture that I think most fertility specialists discount, which I think is a huge lost opportunity for patients. And I think collaborating with acupuncturists, and Christina and I've taken care of a lot of patients together, it just brings the experience for patients from this level to a much higher bar. It's a much more holistic experience where instead of just focusing on what we focus on here, Christina's able to focus on many other things that are very important and admittedly not as well understood by me or as the physicians in our field. And I think that while it may not be for all patients, I think that most patients will get some pretty significant benefit by meeting with people like you.
No, that's so nice that you have that open mind. And I think it's really helpful for the patients too, because, when there's conflicting opinions between their doctor and say, some part of their support team, like someone like myself, it can be very stressful. What benefits, if anything specific, have you seen with your patients that have pursued Eastern medicine or acupuncture or alternative methods?
I've seen a lot of help when it comes to bringing FSH down, when it comes to helping patients who have thin endometrial linings get those linings thicker. Stress reduction probably is the most immediate and obvious benefit. another outlet to somebody who has a lot of experience in the field and has worked with a lot of different physicians in the field and has seen, different types of protocols and different types of approaches, I think is super helpful. And I think the conversations that you have with patients are a very important part of that holistic approach that that you provide, because those conversations are not necessarily happening with me or with other doctors at other fertility centers.
Well, I think, one thing that I counsel my patients in is that, like, you can't, one doctor, one physician cannot be everything for the journey, right? It is a very tumultuous time, and they want fast education. Our listeners are listening now because, there's this information that they can glean and hopefully help them on their path. And as much as you want to be, fulfilling all those roles and advising in all those areas, it's just impossible to be doing so. So I appreciate our collaboration, and I know that we both are of the best service we can in the ways that we, in our fields and in our kind of scope of practice. So what would you leave our patients with in terms of, advice on moving forward, or some pearls of wisdom, and, even just to know that they're on the right path, or what to look for?
I think that the relationship with the physician is probably the most important aspect of a patient's journey in terms of how they're going to feel throughout the process. In New York City, there are lots of options and lots of really smart people. So I encourage patients to very seriously consider, and I know most patients do, of course, to consider the options, do their research. And at the initial consultation is when most patients will, get the feeling that this is the right person or it's not. And I think that having that level of comfort going in, because once you dip your toe in the water and you're on the train, it becomes more difficult to step away and find somebody else, especially once you've started a cycle. So going into a cycle with the confidence in the physician and the practice that this is the right place for you, I think is probably the most important advice that I can impart on